Well, welcome to New York. As you saw, a great case by Dr. Sharma and Dr. Kinney. Really proud to welcome you back to our cath lab and really want to thank you, Jazz, Craig, and the entire organizing committee for giving us the opportunity for doing this case again this year. So we've got a very exciting case and a lot of decisions that need to be made and maybe planning decisions that we did right or wrong, and we're going to talk a little bit about that. But I'm very proud to introduce our team. To my right is Dr. Raman Sharma. He's the assistant director of our endovascular program here. To his right is Dr. Ajit Rao, who's our vascular surgeon, but he's also the director of the vascular surgery research division as well. And he's one of our vascular surgeons. We all work well together. Almost every week we see him 2 or 3 times a week in the cath lab to make tough decisions. To his right is Dr. David Song, who's our new attending this year. He was our endovascular fellow last year and has joined Raman, myself, and Vishal and Karthik here this year. Behind him is Dr. Harsh Doshi. Harsh is here, for doing his endovascular training after a year of interventional cardiology under Robert Pio in Stony Brook. And then we've got Freddie, we've got Jen, and we've got, who else have we got here? I'm sorry? Huh? Anita, I'm so sorry, I can't see her name, and Anita's here as well to help us with this case. So without further ado, George, we're going to get started, and then we can talk about some of the decisions we've made, and you can let us know whether we did it right or wrong. So, Harsh?
Yep, let's get started. So we have a 62-year-old female referred from an outside hospital for bilateral progressive ischemic rest pain for a few months now. Her ABIs were significantly positive on the left. Recently, she had a right SFA and CFA intervention with drug-eluting stents because of a ischemic foot, right toe gangrene, and she's on all the right medications, aspirin, Plavix. Her EF is a little bit low at 30%, so she's on guideline-directed medical therapy except for cilostazol. So when we did the diagnostic peripheral angiogram, we saw that she has a calcified distal SFA CTO that reconstitutes in the popliteal with 2-vessel runoff with a totally occluded anterior tibial artery that reconstitutes in the ankle. Next slide. So these are the distal vessel runoffs. And when we took the aortoiliogram, as you can see on the right side, you have the stent extending into the CFA, but the arch is not specifically, typically that hostile looking. She also, in this point, we also noticed a SFA dissection as well, proximally on the left side. So given all this, we took the patient off the table and discussed, options with our vascular surgery team as well as our endovascular team, and decided that we should attempt to try to treat this CTO using a radial approach.
So George, go ahead. I'm sorry. Go ahead.
Yep. So before we do any radial case, we make sure the patients get radial ultrasound, subclavian ultrasound. Make sure the arch types are suitable, as well as the patient's height. In this case, the radial artery was about over 2.5 centimeters, around 3 centimeters, and there was no obstruction. And she's never had the radial artery intervened on before.
So George, if we go back to the fluoro, I discussed this with Raman and Ajit and David, and we looked at this. And if you go back to the fluoro, you'll be able to see what the problem is. You'll see that there's a common femoral stent that's really across I would say up to the proximal 1/3. The inferior epigastric, which we don't have a picture of, I could take one later to show you, it comes right off at the level of that common femoral, maybe slightly above, 1 millimeter or 2 above it. So it really precludes us, in my opinion, to do an up and over intervention when we have the radial access. And so maybe Raman can discuss our choices of accesses here and why we decided to go with the radial, and maybe you guys may or may not agree. So Raman?
Yeah. So assuming that we're going to be not going by the the approach from the right CFA, the most typical option that we'll have, especially at this institution, will be either to go from the left radial. That'll minimize any kind of excessive tortuosity that you may get as opposed to the contralateral right radial artery, or just go by a retrograde approach from the ipsilateral tibial. And she definitely has patent tibial vessels going all the way down to the foot, and the PT and peroneal. The AT may be occluded, but the PT is robust in making its way all the way up.
Mm-hmm. And I can show the picture of it. So let me show you guys the picture. So go ahead. You talk, and then I'll show them the picture.
So we have, the question then just comes down to, and that's going to be, I guess, at the
forefront.
But
what about antegrade? Why wouldn't you go antegrade here because of the dissection, or?
Yeah, I mean, it looked like from our previous images that there is enough significant disease that we don't really have enough room of any sheath, even if you go with a very short sheath, to actually treat proximally safely. And it really thought if you really account for that proximal disease and we do decide to actually treat it, we need to be able to deliver equipment through a sheath safely. And we just don't really have enough landing room at that proximal left CFA area.
And Ajit, can you comment on brachial? We used to do brachial all the time, and why you decided not to do brachial here?
Yeah, I mean, I think it's definitely higher risk than radial artery access. A lot of times, if you just hold pressure, you can get a hematoma. You could get a brachial sheath hematoma, and that can become a surgical emergency to drain it. Otherwise, the patient will get like neurologic deficits. We don't really have good closure devices or really any closure devices for that. So I think with brachial access, my practice has always been to just do a cut down if that's the only option.
Right.
But I think it's definitely higher risk than doing radial artery access.
So before we comment on the access options, I just want to go over the angiogram here. So you could see that her ankle pressures are low because the flow is bad. You can see here, proximally the flow is bad, very sluggish. Profunda doesn't really have robust collateralization. It actually SFA to the distal P2 segment P2 segment reconstitution. And you can see the flow, it looks robust there, but when you see the flow on DSA, not really the best. This is really timed quite a bit. This is your occlusion. And you can see that the occlusion fills. And you can see that it's a heavily calcified, or at least looking calcified. I wouldn't say heavily, but calcified. And then you can see the reconstitution of the P2 segment there. And then in the next picture, here we go. There we go. Sorry. You could see here that that George and everyone there, you can see here that you have very distal reconstitution of your popliteal, AT occluded like Raman said. And then you could see the foot shot here. The posterior tibial seems to be the really dominant flow to the foot. And that was one of our hesitations. I know it's rest pain, it's not a wound, but we didn't want to necessarily get access because the perineal kind of peters off. So we didn't want to get access here. So that was our decision to go left radial. I'm curious on your comments before we show you what we've done.
Yeah, so I've got Anish up here with me, obviously, Vishal, who you obviously know is not there, Matthews, and Steely. So I would tell you, I would have the foot prep, but I would go left radial. The only thing I would be careful with is, when you re-enter, you're at a place where if you re-enter clean, then I think you're good for the foreseeable future. If things get dissected and torn up and you end up extending down to behind and below the knee, then I think that becomes problematic. So I think your strategy is very sound coming around from the left radial. It's just, if there's any trouble crossing from above, I would stick the foot before I messed up the landing zone.
That's a great point.
What do you guys think? We'll just
I
kind
agree
of
with you,
quickly
George.
go.
I think that's a good point. I think prepping the foot would be good for two reasons. One is if you fail to cross antegrade, you can, you don't have to put a sheath in the PT. It's your dominant runoff into the foot. You can at least cross and externalize. And then yes, as a bailout, it's a good option. Honestly, I think this is where, limitation of equipment from an R2P approach is always a problem. Ideally the stent, if you want to put a stent there, superior would be optimal, but you're stuck with a sheath size. Honestly, if you treat that ostial SFA, that ostial proximal SFA, that dissected zone where you think it is, antegrade could still be an option. It's not, an antegrade common femoral is still an option though.
Yeah, we didn't see the height. Are you pretty confident you can get whatever you need
Well,
to get?
it was funny. We asked the nurses right before, but to get the information. So she's 5'3", right? No, 5'5", excuse me. 100 and how many centimeters? 155, 60, 165 centimeters. So we thought we have enough equipment to go down. And that's what I want to show you now so you guys can see exactly what you were talking about is the limitations of this particular way of doing things, I guess. So I want to show you here as we get access. Let me go all the way to the front again. I apologize. Let me see. There we go. So I'm going to play this. And you can see here, we went with a woolly wire radial access with radial cocktail given, traditional IC style. And then you can see we follow the woolly wire all the way up. I mean, I don't believe in using the Terumo. I know a lot of cardiologists do. I feel that the woolly is just as safe and just as effective. And so we go all the way up top. And then once we are able to cross in and go to the ascending aorta, we track our what is it called, vert tip catheter. Up to the top, pull it into the arch, and then obviously pull it down, point it to the distal aorta, the descending aorta, and then as we go forward, the woolly wire just prolapses right in very easily right there, and you can see that in a second. So once that goes in, you can see the arch is very tortuous. I want you to see, we went ahead and got the access, and then we did the diagnostics as I showed you. And then I want you to see the actual wire. So there's your catheter now. That's the 125 vert tip. And look at the wire. So the wire is all the way here. So then we went ahead with the 119. Am I right, guys? 119 Terumo sheath. Yep. And the 119 Terumo sheath took us to the common femoral right there. So with that being said, we wanted to cross offline. I mean, crossing is not the reason we're doing this case. So we went ahead with a 150 Terumo catheter. And then we went with an 018 wire, which we failed. So Raman and I decided to go with an 035. And you can see here, we pushed the catheter down without much problem. And then we're able to enter just distal to the lesion. And because of that, we had no problem crossing. And then we went ahead and put a what length wire? 240? 240 length 018 Terumo wire down into the foot. And we did an IVUS. So, so the IVUS got up to where? Where did the IVUS go up to?
Proximal SFA.
This is the IVUS. So the IVUS got up to the proximal SFA, and talk about equipment, Anish and Jay. This is where we are. So we got the IVUS up to here, and would not see anything beyond this area. Forgive me, I like radiating my hands, I guess. And then when we got to this point, where you could see that the IVUS was no further than that. Okay, I think the point's proven, guys. Let's go live on the IVUS. And you can see live on the IVUS, the proximal SFA is dissected, as we thought. And there's our dissection in the prox. And then we have the distal CTO. So this is part of the reason I think she's having it. She has multi-level disease. She has obviously a disease profunda. She has a prox SFA dissection. She has SFA to popliteal genicular collaterals, which seem to be dominant, which are compromised by the dissection of the SFA and the CTO of the distal P2 segment, P1, P2 segment. So therefore, I think fixing this would help. And that's where we are. So, I mean, equipment-wise, I don't know. What are your thoughts? Raman, Ajit, what are you guys going to do? What do you think?
I mean, I think that if the 150 of the IVUS didn't really come down, then we are truly very much limited in terms of what we need to get to the most distal portion of the CTO. That's why we have, we have to go with the devices that are the 180, 200 lengths to really get to where we need to go. That does take a lot of the equipment that we would more traditionally like to use, like a Supera. Unfortunately, is not going to be something that's going to make it there. The other DCBs we may use, although we have different lengths here, it changes significantly.
And DES too, right?
And DES as well. Atherectomy devices, should we choose to go down that route. And even I think just even when it comes down to even just the lack of getting the full imaging of this actual lesion, we just don't have the equipment really available for us. So we don't really know. We thought it was calcified-ish, but it's hard to really say without.
It was hard to cross, though.
Yeah, it was hard to cross, but.
So, question, Ajit, would you? I'm just curious. So, the panel, would you guys get pedal access now and just do it from the pedal with a 6 French sheath, Ajit?
I mean, I think if you have the pushability from above, it's probably better to avoid the main runoff to the foot. So, I think our approach would be to try to treat from above first, and then use that as a backup if we need it. I don't know if the panel feels any differently.
It looks like people are mixed. What do you think, Jay?
Yeah, I mean, I just do this from the foot. It's a lot of work, and we're kind of doing things with one hand tied behind our back. As Anish was mentioning, we don't yet have the full armamentarium of technologies available to do this. So I think that I would have a low threshold to go pedal.
So that's a great point, Jay. But I mean, as the single solitary runoff to the foot. I mean, are you worried about that putting a sheath in that?
Yeah. I think the point is that you have to use ultrasound, be very atraumatic, and be meticulous. And I think the risk, and then you're going to check it on the way out when you take it out. You're going to, if you may need to put a gentle balloon inflation across it when you take that sheath out.
And I agree with Jay. You'll have difficulty in support. To get enough support. To cross through. I think foot. Definitely.
I mean, everybody knows that PK is my boss, and I love Raman and Ajit there, but I would have gone pedal first in this case because I understand.
Traitor!
I think you need to stay there, George. You have a job there. Raman and I have already decided. He has to stay there.
Should I postpone my flight?
Just cancel it.
Exactly.
Yeah.
Go ahead. I'm
So
sorry.
BK, one option is why don't you stent that dissected ostial proximal SFA and then go antegrade? That way you avoid pedal completely, right?
Well, I agree. Ajit, any thoughts on going through a fresh stent with a sheath?
Yeah, I mean, I
mean,
think.
it makes sense.
Go ahead. I was just going to say, I mean, I think, it's just another access point, and the more access points you have, the more chances for complication, and especially since we don't have the contralateral access. If we have issues with that antegrade access, there's fewer bailouts in terms of like tamponade and things like that. So I think I think simpler might be, better here as long as we have the pushability.
Well, a couple of things. I just want to correct myself. I was corrected by a team. It's a 400 018 wire from Terumo. Only problem I have with that is it's a glide-coated wire, which I'm not very fond of, and we know that we're not going to be watching as we're making these difficult exchanges. But maybe, as we're going to tell you what we're going to do, because we already, I think we believe that we have the equipment to deliver this. So we have a drug-coated balloon from Medtronic, as well as other companies, and the shaft length on that is, guys? 200 shaft length, and it's obviously the impact balloon that's been studied. We have the Misago stent from Terumo, which also has a 200 shaft length, which can be studied. So the only problem here is the shock wave is 150, and our fellow Harsh Doshi was kind enough to prepare a overview of radial stuff so the audience can learn about some of the limitations and we can discuss, while Ramami and Ajit are going to do prolonged balloon angioplasty and get the vessel ready while he does that. So if you guys allow it, we'll do it.
Yeah, so PK, the consideration is how would you want to end this case? And if in that area, I agree with doing a DCB, but if I was going to bail out or do any spot stenting, I would want to use a Supera, which will go through a 5/6 slender, which I would stick in the tibial instead of using a stent that I don't think is great for that area, just so you can stay radial. But that's just me.
Okay. So let's. I just wanted to I guess we'll balloon and let's see what we find out. So we're going to go with the balloon while you can put up his slides and you guys can comment on what he's going to say. We prepared this, all of us together, so it'll be interesting to see what your thoughts are. So we're going with a 4.0 pre-dill balloon, just to let you know, 4.0 150, 018 Medtronic balloon, and we're going to take it up to the point where we think it is occluded.
We also have like longer balloons with Metacross balloons, which go all the way 200 shaft length, which can take you down all the way to the
too far.
Yeah.
Too far.
Yeah,
Yeah,
I think,
right.
I
We're
think
right
the
above
issue is
it.
that you've got
Right here?
balloons that have outpaced.
Put up the PowerPoint.
So
Denise?
that's the
Yeah,
problem.
put up the
Because
PowerPoint.
There's no bailout. If the balloon fails for whatever reasons, now
Sorry.
what's your plan
Yeah,
B?
but you're going to have to use the Misago.
Yeah.
So,
Exactly.
And they
Let's see what the proximal lesion is.
yeah, the Misago's radial I mean, it does reasonably well, but I think it's no Supera for sure.
Yeah, but I think a very important point they brought up is before you decide going on your left radial axis as your treatment strategy, you have to consider a lot of important points.
Show me
The
above, guys, the
height being
proximal down.
The arch anatomy is very important.
Sorry.
The tortuosity of the iliac,
Perfect.
because everything
Little
will
diagram.
foreshorten your final sheet.
Little
Even
di-
though you might have a 119 Terumo sheet, everything will start foreshortening if the angulation and everything changes. So now you're barely not reaching your treatment point.
that's
So I
close
think
to
that's
patient.
very important
it's
to
close.
consider. And radial spasms also become a big issue. Old, petite ladies can have issues with radial spasms. Something to consider and before you start doing all this.
So we've got a very quick overview, which I think will bring up a lot of discussion. Harsh?
Yeah, thank you guys for having me. I think so radial artery use, as we know, for coronary procedures has shown improved patient-centered outcomes in the coronary world. However, there's a dearth of data regarding this use in the peripheral space. There was a prospective multi-center registry that was done that showed that, doing radial artery peripheral interventions improves patient satisfaction in terms of time to ambulation, low mean procedure time. However, when this study was conducted, the destination therapy for half the patients was POBA only in the SFA, and at that time DCBs weren't really used universally in peripheral interventions. So despite its reported high technical success rate, radial artery intervention has a very slow uptake in peripheral interventions. In fact, it's used less than 1.5% of all endovascular interventions in the United States. However, as time has progressed, newer technology with longer shaft lengths, with different types of preparation devices have been developed to be used in the radial world. So there are no large prospective randomized trials that are there for radial versus femoral versus pedal. There's a small one that I'll go into briefly, but given the increase in endovascular interventions as a whole for treating peripheral arterial disease, I'm sure this question will be addressed. So in terms of best practices and how to, go about going with radial artery interventions for the peripherally. So before we even start, we examine the patient. I know in the coronary world, the Allen and Barbeau test has fallen out of favor, but it's still something we like to check here in the peripheral world. We always go with ultrasound because radial artery size less than 2.5 millimeters has shown increased risk of spasm, which we don't want, especially with our large sheets and bulky devices. Patient anatomy is taken into consideration, as well as the actual peripheral vasculature. What are you dealing with? Are you dealing with the TAS CD lesion, which requires a lot more preparation, or are you dealing with something short above the knee lesions with non-hostile iliac? Other things that we do is we make sure we give for us, in our institution, we use radial cocktails such as heparin, nitroglycerin, and verapamil. We also place patients, if their blood pressure allows, on an IV nitro drip and give them very heavy sedation with high ACT goals. The sheath that we use, the R2P sheath, is extremely hydrophilic, so it's extremely important to make sure that's wetted before you insert the sheath, and frequent flushing. So another thing to keep in mind is where are you performing your intervention, because where you decide to do your intervention really dictates what you can use based on the distances from the radial artery to where you're deciding to do the intervention. The room setup also varies. So for us, we use right side access with left arm crossover. You can flip the room around as well to make it more ergonomically convenient. And then radial artery complications are from minor hematomas all the way to compartment syndrome, which is very rare, less than 1%, but it's still something to be aware of, especially radial artery spasm and radial artery occlusion, which we can reduce by making sure that the radial artery caliber is large. We use hydrophilic sheets and frequent administration of vasodilators and anticoagulation. So there was a TRI-ACCESS study done a couple years ago that was a prospective randomized trial comparing radial artery, femoral artery, and transpedal access for the treatment of symptomatic SFA disease. And although there was no difference in MACE or major adverse limb events, technical success was achieved in pretty much all groups. The major difference, honestly, was that the access site complications were lower in the radial artery group than the femoral artery, but radiation exposure was higher in the radial artery group. And in talking about the access site complications, in this particular study, femoral closure devices were not used. And so these findings have also been reinforced by meta-analyses comparing transradial to transfemoral, just in terms of complication rate and procedure completion, procedure success rate. So, established benefits of radial artery interventions that are, reduction in time to discharge, reduction in time to ambulation. However, there's really no randomized or long-term study in these complex lesions that we deal with in terms of long-term MACE male events, target vessel revascularization rates, especially since, like we'll talk about, current compatible devices such as drug-eluting stents, which we know are very beneficial for SFA disease in terms of long-term patency and long-term outcomes, are not available in the radial world at this particular stage. In fact, even in atherectomy, the only thing available right now is orbital atherectomy, laser by angiodynamics. We have some DCBs of various companies, as well as shockwave, but the shockwave length, as we saw, was 150. That's why in this particular case, we aren't even able to use shockwave despite the moderate to severe calcification that we see on angiography. And we don't know if that'll affect the patient's long-term outcomes because, again, we don't have that data. So overall, there are some advantages favoring a radial approach. It just depends on what kind of lesion you're treating, how simple it is, how complex it is. But pedal and femoral still have a role in today's age. I think there's still work to be done in the radial world.
Yeah. So thanks so much, Harsh. Great job. So, I mean, as you see, guys, a lot to discuss with that. So Raman and I went up with this 4.0 balloon here just to get our thing. So 4.018 balloon, and you can see here it expanded really nicely. And I just want a fluoro to show you the expansion, just to show you that the calcification may not be as bad, even though we didn't have an IVUS. Maybe you can rotate the gantry. So Raman's just going to rotate the gantry to just to show you that the balloon is well expanded on both ends. So you can see that there's really no dent in the balloon. So I'm not sure. And guys, we'll take a picture here and then we'll decide on what to do. So maybe when you get a chance, let's go down.
So the only caveat to the comparison to coronaries is that you have a short sheath in the radial, you're doing a coronary, and this one is extending from the radial all the way down into the leg. So the spasm situation is much, much different, and the risk of, you know, having problems with that is a lot higher. And so, you know, I think you brought up a couple good points, one of which is sedation. So when you get in horrible trouble with one of these long sheaths, the only thing that's going to work is anesthesia.
Yep.
You can try to give nitro and do all this stuff. The only thing that's going to work is knocking them out to where everything relaxes, and you can use a stiff wire and then kind of
You can just pull.
out.
It'll
So
be fine.
that's the only thing I'd
with
say
the
about trying to make
wires
apples to
bent.
apples.
Yeah, just pull it.
A short sheath to a long sheath.
Oh,
is
wire
gonna
bent?
do-
Oh, shoot. Okay.
Yeah.
The other thing too is you want an ultrasound. Typically,
Yeah,
it
wire.
runs into trouble if the radial artery is less than
Yeah.
2 millimeters in size.
Yeah.
So you want to have at least a minimum of 2 millimeter size vessel.
You want to take the balloon down and change the wire out?
Yeah.
Yeah. So we have a little bent issue with the wire, which can happen when these long 200 millimeters. So we're just going to put the balloon back down and just change the wire out and then walk it out. So you know, a couple of things, guys, I just want to go over. So in the trial, the Misago trial, the stent fracture rate was, that's good, right? Was between 2 to 3% at 3 years. So when you look at Silver PTX, again, 2.8% fracture rate. And you know, it's a, you know, so fracture may not be the issue here that we need to worry about. Very, very small fracture rate, not heavily calcified. So I think that may be something that to think about here. You know, I just don't know about the natural history. Maybe Ajit can comment on this. I mean, we both get pedal access all the time, and like we do in our cath lab. Ajit does it all the time with his team in the OR. But my only question is, what do you think, Ajit? I mean, about getting these accesses in the pedal lesions?
I mean, I think we actually just are writing up our experience, but I think if you prep the vessel well, you know, similar to how you do give a cocktail for the radial, and you're careful about it with good technique, and trying to minimize what sheet size you're putting in there, I think you can do it safely and effectively. That being said, I mean, in the case like this with one vessel main runoff where you have potential other options, it wouldn't be my first choice, but I do think it can be done safely and effectively for, you know, but there is, you
the balloon down a little,
know, you have to think about what would happen if that vessel goes down, you know, and if it's multi-vessel, it may not be significant. If it's one vessel, then you could end up with a acute limb ischemia. Yeah,
you know, Tak Wan, who's one of our colleagues who actually used to be at Sinai, now is at Lenox Hill, he published his data with his group about outcomes. But again, it was 30-day reported outcomes, no long-term outcomes, single center, no core lab. So, you know, I'm kind of skeptical. You know, I know, Jay, I know we do a lot of it, and I think in our hands, I think it's probably okay, but I think you got to be very careful. And this lady, yes, she's rest pain, yes. And at the same time, you know, we have ankle pressures from the outside showing that the ankle pressures were on 75. So, you know, we have an ultrasound from the outside, which again, didn't have any images for me to show you. It wasn't like sent to us by ultrasound by our lab. So, you know, to me, it's like she's bordering on Rutherford 3 to 4. And I think if we open up this inflow and not mess with the outflow, she'll do really well. So since we've walked it out now, we're going to go ahead and do a DSA for you guys, and we'll take a look at how it looks. Ready, guys? DSA when you get a chance?
I think this case will become like a two-step or two-day
Ready?
procedure where you actually improve the inflow, do a DCB of the outflow. If non-flow limiting dissection, leave it, and bring it back another day for antegrade access to have that nice angiographic result eventually. But here it looks very good for now. So
there's your outflow. You know, it looks pretty good from the common femoral. So now we're going to go ahead and apply a DCB. I think you guys all agree, right?
Yeah.
So we normally IVUS size. So now we're going to balloons eye size. So let's take a vote. I mean, Raman, Ajit, what do you guys think?
6.5 SFA.
I would do, I think the proximal was around a little over 6. So I'd say 5 or 6. 5 to 6? Yeah.
How would you guys size this? 6.0 is fine, guys. 6.0, 150 or 6.02.
Any rule of atherectomy in this case?
What's that?
For the proximal part, any atherectomy?
I don't think so.
Only
The
two.
only atherectomy you have is it's a
Well,
dissected
for that-
segment, and
Only
then
two.
this is. I don't think either atherectomy is going to really
Yeah,
do
it's
anything.
a dissected area approximately. I think you can just cover it up with something.
Well, for the proximal, I'm curious what our team thinks. What do you guys think? Just direct DS? Just put a direct alluvial silver?
Yeah, I think
130
so.
should reach, right?
Right.
What do you think, Roman?
Yeah.
Well, the 150 got us to the proximal. So I mean, we'll be cutting it close.
We'll try.
Yeah.
I mean, you know, that's a good point. What
Yeah.
Roman is saying. It's
The
cutting it
IVUS.
close.
The IVUS barely made it
You could
down.
also DCB it and then just put a bare metal in too.
Yeah.
Yeah.
Yeah, but
Still
guys,
get drug.
the question here is Radial ready for prime time? I mean, Terumo, Medtronic, they're all making their Radial products. But here's the case. Honestly, this is a vanilla case. I mean, if I did this for a regular, conference just to show you guys, be like, what's PK thinking? That's the reason why, the Ram and me and Vishal picked this case. We were thinking about how, along with David, how we can actually figure out, and make some decisions, because everybody's pushing R2P. Did I cross or no? I can't
No.
quite see.
Not
Okay.
yet.
Everybody's pushing R2P. I think I might have crossed. No? No way, right?
No.
Show me above.
Well, PK, I mean, it's an outpatient phenomenon, right? I mean, you want to do radial so you can get people up,
There you
get
are.
them out the door quickly. I mean, that's the whole push.
Because
But
it's not coming.
my idea
No, you're
is,
still
I usually
proximal.
stop around proximal.
It's really not
SFA
going. It's
because
a lot of
if
resistance.
if I can't
There you
get
go. I
every
see
piece
what
of
you're saying.
equipment that
There
I
it is.
ostensibly want
Sorry,
to use
man.
for the case,
I know you
then
made fun of
that's
your
not
last
gonna
case.
5, I
success.
think, right?
I think
Right there?
here you had to do,
think
you had to
basal.
A
do-
little bit lower.
I also think
different.
that,
5.
you can use whatever equipment is available, because you don't want
5.
to turn this lady.
Little
into
back.
acute. I think that's a very important
Especially
point.
with the claudican with
There's a
no-
dissection up to
We'll
5.
Yeah,
take
it's a-
restenosis.
Down-
and
down to 5.
Whatever
Floor?
over turning her into.
Down to
acute.
5.
Yeah.
So
We're
I
gonna have
think
to go.
everything's
Flora?
Yep.
done, really
We're on.
appropriately.
Not moving.
Yeah, sheath being kicked
But the
back.
short answer is no, it's not really fully ready for prime time.
There you go. Good.
Not for distal lesions. Like
Yeah.
that.
For above knee, as you said, George, above knee is a fair game, but below,
Yeah, I mean, it's just, again, if you can't get everything you want
yeah,
through
that's
that
the problem.
access, then it's not a good access. So for me, the limitation is that.
Well,
And so that's why-
Georgie, CSI, we could have done it. I keep calling it CSI. Orbital atherectomy, we could have done it. Abbott, is incredible in that they're really doing a good job in doing education with that particular product. And I got to tell you that, but the problem we had here is the dissection. And the problem is our cross, and we couldn't do IVUS to see how good it was. She's having some pain, guys, to see how good it was. So therefore, we obviously are not going to take the orbital atherectomy to go ahead and do it. So we're going with the impact here, which is impact 60150, and we're going to leave it up for our 3 minutes.
No,
So-
but PK, the thing is, what I'm saying is, before you plan the
I think
case.
we had to go
you
higher,
have your
too.
pros
We need
and
another
cons,
balloon.
Right?
Second one, yeah.
So I'm just saying, if all
Another
things are
150.
equal, before I start a case.
Another-
I wanna
probably
make
100 or
sure
80?
Everything I want
Actually, give us 100.
through that access.
So
site.
even
we're
with
gonna
the
do a
dissection
stent
there,
proximate, right?
Arion is you can do that.
do a
potentially as
roadmap
well,
here?
too.
Let's see.
Hopefully Philips will have their version.
I
as
just
well, too,
float
that's
out
in,
of that.
But there are options for patients with dissection beyond just, orbital and whatnot too.
Sure, but I mean, I'd also just cover it with a DS. I mean,
this
that's a
one, right?
proximal huge SFA.
This is
I
roadmap,
mean,
right? Yeah.
Hopefully you should be able to reach, but again, they're cutting it
think it-
close.
yeah.
It's-
Yeah.
You're,
We don't
you
need
end
an
up
80.
getting the stent there and you realize it's
One-
not long enough.
100.
You don't have enough runway.
They only
it's a
have-
problem.
Oh, it only has 150 or
They only have
150.
80. They
And I
have
agree
the
with you,
80.
George. I
Oh,
think,
they have 80.
you
80
know,
will be good.
not being ready for prime time is absolutely the case, because PK, the other thing that's worrisome on this angio is just in the P2 segment where you re-entered. I mean, it does look like, at least on single view, it looks like there is a pretty significant dissection there. The question is, will DCB pack it up? Right?
Yeah.
If you can just show us that angio again.
Yeah. Well,
Both PT is-
I mean, Anish, I think we'll come off roadmap here. We'll just put the balloon on top of this one. Anish, I mean, we entered right at the cap, so we did not go any further. So yeah, there's 100% dissection there. There's no question. I think that what we have to do is I don't think there's any reason. That's exactly where we entered, right by
Yeah.
5. So right above 5. So you can see the dissection is there. So we're gonna have to tack it up. I'm kind of in the corner of a JIT, and even I'm not sure about Raman, he hasn't mentioned it, is that I probably would not put a sheath in this. I think do it with the Misago, deal with it. It's not a horrible ulcer, not a gangrene. It's a rest pain patient. We've got DCB. If we're able to pull this off from above, I think that's fine. I mean, I don't think atherectomy would have added anything to this in terms of our outcomes. I think if anything, DCB is the only thing that's going to add to this. The Misago is going to work as a scaffold to help us, and the fracture rates are quite low. So I think that's what probably I would do. I don't know, Raman, would you put a sheath in for the Sapera just for this?
Yeah, I mean, I think it comes down to, as George was saying, like, hey, before you decide what your treatment is going to be, like how you want to end the case, is how are you going to begin with everything. And I think that's where you kind of really take your time to really think about what equipment you're going to be able to actually deliver to give you your desired destination therapy. And I think that if, you know, if I'd be very, very happy if we can actually end with just a DCB and nothing.
Sure.
You know, that would be best case scenario. I think that's why we've agreed to go down the route of the radial route. And if we do end up having to
21,
put,
we stop it.
if we do have to end up putting
Go ahead.
the Masago, then, you know, then at least we know that this is, it's not as if it's terrible data. Yes, there is data that is more, suggests that there is patency, that is improved with Supera, but it's not terrible data. You know, it's not as
No,
if
I
we,
mean, absolutely not. Now you've got an impact DCB. Now,
correct.
impact
Yeah,
plus
so
Masago, question
should
is how
work.
much is
It's-
that going to affect
well,
ISR?
Yeah, well, the question is, obviously Raman and PK know what they're doing, but the superior deployment from the tibial is not exactly easy.
Yeah,
Especially if you're trying to
exactly.
stay out of things, right? Because if it elongates on you now, all of a sudden you're going the wrong
Yeah.
direction with your elongation.
That's true.
I think for the record, I agree with PK.
Leave it right there so we can see 21. He wants to come back home, Jay. He wants to come back
Go,
home.
Matt, or you just want to go?
Yeah,
No, just go.
let's
We'll just
come
go with
back
it.
home.
So we're gonna go with the second DCB and take a picture. I know we got 4:15 is our hard stop, so we're gonna do the second DCB. The only other question I want to ask you guys, and maybe Ajit can talk about this. Ajit, when we do this bit with these stents, now obviously we're ballooning and stenting in the P2 segment. There's a lot of data with there is data, I shouldn't say a lot of data, from the old basal study that showed that interventions causes worst outcomes with grafts, right? So my question is, when we get these pedal accesses, I know we don't know, but what's your gut? You've operated on these patients that you've actually done pedal access on. Have you seen outcomes that are any worse?
I mean, I think, maybe not so much the pedal access, but I think, when you're doing atherectomy and all these interventions, there's probably some particles that are going to the foot. And multiple interventions, I have seen the outflow kind of, be compromised in patients that have had it, for years. And that can affect your patency of your bypass. Outflow is usually the one that we can't really fix most of the time. So I do think, it does take its toll. And
It went down, huh?
I think there is some data to support that. So if, if this patient, you had a patient that potentially you're debating between doing this or a vein bypass, I think, that's definitely something to consider if they have good vein.
So would you bypass this as a claudication/rest pain?
I guess question one is if they have vein, which I'm not sure if this patient does. I think it's just a discussion to have with the patient. I think this intervention, especially with what we're doing, if we're going to end up stenting in the popliteal segment, is not going to do as well as a vein bypass. We know that. So, you're kind of subjecting that patient to repeat interventions. So they have to be aware of that.
Yeah. Okay.
Ajit, just a quick question. What about the option of how you do in TAVR where on the right groin, if you have a controlled open access and you build a conduit and do all your intervention, and then through that 1-inch incision, you can actually close the right CFA and then still not worry about complication with it. Would that be an option?
Yeah, a lot of the TAVRs we do here, pretty much all of them are done under local sedation, and we're able to kind of deliver the device. So, that's the other discussion point is just the right common femoral is, why we're even having this case in the first place. But in my opinion, that patient should have probably just got an endarterectomy, and then, we wouldn't have to worry about coming up with these creative access points.
What we've created, George and Jay and Anish, is that in Sinai, we have literally, it's an unofficial vascular team. We discuss a lot of our cases together, especially these kind of cases. We all do our PTABs and our DVAs together. We do the carotids together. It's really, I think we're providing good care, and I think it's time for a vascular team approach, like you guys have a complex coronary team, a TAVR team, or a structural heart team. I think it's time for a vascular team in these kind of cases, because I think the multidisciplinary approach at the end, I think, is going to win in terms of outcomes for the patient. All right, so we're almost at 2 minutes, and then we'll drop the balloon.
So while you guys are working, I'm just drawing something on this screen here because you guys have brought up a good point about common femorals. So I think what they're trying to say is originally you have to look at where the disease was in the CFA.
What's the nitro drip at?
The disease was just here.
Double it because the pressure's going up. She's probably in some pain.
Profunda and SFA, now it's actually a very complicated deal. And so if you know this going in and you're going to have to take your stent all the way up here, and go across the profunda, it's not really an amazing situation. So there's lots of data for common femoral endarterectomy. There's emerging data, there's good data. So I'm not going to start arguing with PK now with 5 minutes left in the case about CFA stuff. But endarterectomy is tried and true. I mean, it's a good operation in the hands of a good surgeon, experienced center, and it gets you out of this sort of jam in the future.
I guess when
Yeah.
if you talk to Tom Zeller, he'll tell you about the right
No,
CFA
I
stenting and how
know,
that
I
works.
know.
But that's a chapter for another day.
Well, yeah, I mean, the other discussion point is this patient has contralateral PAD, so you're burning that bridge for an access point too. So, it would be different if it was potentially if it was just one side.
Would you ever remove the stent on the right CFA? Would you ever plan, like, if it is going to be something that this is something that that she needs?
Yeah, we've
she
had a couple of
has-
those cases where,
Yeah.
like,
Yeah.
in an emergency situation, we bring them back and electively
Ready,
remove
guys?
the stent
One
once
more
they've
little lower.
recovered.
Yeah, right there.
But in this case, I
DSA?
would do an endarterectomy up until the SFA, and then just
would go back on the
remove the
nitro.
stent that's in the common femoral, portion of the common femoral.
And how easy would it be to cut across the portion of the stent
You can
that
do it.
extends to the CFA?
It's not too bad.
SFA?
Yeah, you just get wire cutters or heavy scissors.
Okay, so you guys saw that. I'm going to do the proximal dissection.
Beautiful. That's beautiful.
Great result.
Okay.
Good job,
Yeah,
brother.
you're done there.
I think so.
Are you serious? Guys,
Yeah.
the proximal dissection is right there.
It's just a
Fix
sheath.
this dissection, and then I'm sure you guys have better things to do at 4 o'clock in the afternoon. and
Wait,
you
wait,
want-
wait. Don't say that. Well, Raman and I are ready for the good to leave. No, but the question I want to ask you is this, is that why would you, based on what would you leave this? I'm curious.
The flow is great. I mean,
What does he want to do?
I mean, I'm not that worried about that dissected area.
Great.
Well,
Well,
Would leave it.
you would leave it too? Rajit?
I don't know. I would say there's a spot there that's probably at least 30% residual
Exactly.
stenosis.
There's
and so
there's a spot that's 30%.
I think you'll do fine in the short term, but then midterm, long term, I think is where you could have early
Yeah.
failures. I don't know.
I think we're also remember we're quite zoomed out here.
All right, you want to go to
Yeah,
another
around 20,
Let's do it.
there's.
Yeah.
Yeah, I'm going to go to another view because I think
But
And I'll zoom in.
this is
Yeah.
where IVUS would really help you too.
I know,
if you
but
have-
Let's zoom in here.
there's another view of that that area. We think we have a little bit of a issue going on.
Schmutz.
So you see right there? See the lumen? The lumen is probably less
Yeah,
than.
definitely can see it spiraled. You're right.
Yeah.
Yeah.
All right.
Yep. I think you're right. I mean, you can easily put a Masago there and get out because you're not going to, you can.
Get us a Masago 6.0.
Yeah. Or 7.
I don't know.
That's all they have?
Price.
All right, so we're. So,
It looks worse than
oh,
that.
you have 160? All right, so we're going to put a 6.0 100, just cover the dissected spots.
Yeah.
So give us the Masago 6.0 100. We're not going to go with a long one. And oh, sorry, Raman's walking them out here. So and then what we're going to do is, for the sake of time, we're probably just going to DES or the proximal, and then we'll be done. I got it, Raman. You got it. So we're just going to show the deployment of the Masago. So I think this is a great case. I mean, I think we all would agree R2P is fantastic and definitely a tool that we need. Probably not ready for every case at this stage, although, I think Terumo and all the other companies are doing a great job working for it. And I think this case should be something that they should look at as something that possibly they need to, develop longer products. Also for Philips, for the IVUS, imaging wise, I don't think OCT, George, you would know better, and Raman probably know better with OCT, what the lens are. But
monorail.
OCT is another thing that
monorail?
would have been useful,
Yeah,
but
but
unfortunately, we
we
don't have the lens with that either. So all these things are a problem, for us to do it. So we're prepping the Masago stent. Jit, you want to talk them through it?
Yeah, so this is a rapid exchange. So we just flush the tip of the, I don't know if you can, how well you can see, but we just flush the tip of it, and then we're just loading it on the wire.
So unlike the over the wire stents, it's a rapid exchange, so you need to flush the tip.
Correct.
And I think Raman has already put the thing on roadmap, I hope. And if he didn't, we'll do it as soon as we get down there.
No, I didn't.
Yeah, let's just save this as roadmap, guys. Oh yeah, we'll just go. You want to go to the other view? Okay.
Yeah.
So we'll get down there and we'll do the roadmap. So it's actually quite trackable. It's a beautiful stent. So I'm gonna go. I'm actually having no resistance taking it down.
I have to say, the delivery shaft seems very, very low profile.
Very
Impressed with
low.
that.
It's going so smooth. Wow. Really, really smooth. Is that the spot, guys? I
Yeah,
can't remember.
let's do
A little bit higher.
Yeah, let's do a roadmap here. I'll
On-
just cover this.
A little bit higher.
I think it's good.
Yeah.
Pull
we have
back
to
a
pull it
tiny bit.
Come back slightly.
Yeah, to like
Just like a
27.
centimeter. Let's.
Back.
Yeah, back to 27.
We're just at the end of the dissection up top. So.
So
Mhm.
I apologize. Slightly coming back.
Yeah.
There?
Yeah, I think right there is
Okay.
good.
So Raman is going to deploy this. You want to talk through it, brother?
Yeah, I mean, luckily these have a lot of instruction on them. You push,
You have to push,
push
down.
the wheel first. Hear that click. And just gonna make sure this doesn't
Go forward a
move
little
too
bit.
much. Yeah.
Just going to go forward a little
Yeah.
bit for him. Little forward pressure. There you go. There you go. You got it.
Okay.
Mhm.
Okay.
Now you
That's
got it.
it.
It's anchored now.
Not all the stents come with an illustrated instruction manual on them. But,
Okay. I'll walk it out. So I'm going to take a DSA. And then, so
Someone
George,
said use the right thumb, not the left.
so George, we'll take a DSA and then we're going to post dilate this. Or actually, do you want us to IVUS and stent the other one off online? Do we have time for that, or what do you think?
What we can do here is the people who want to break off and go upstairs to the different hands-on sessions.
DSA.
Go ahead and break off, and we can stay here. And if you need to take a break, that's fine. We got a few minutes before the next live case.
Well,
That's
George, I think
beautiful.
we're done then, because we'll do that offline. That's not a big deal. I think, we'll stop here. I want to thank you. We're going to post dilate this, stent the proximal, and I think we'll be done. I'll just show you the runoff before everybody goes to the other session to show you that our runoff is still intact. And then we'll go ahead and take a picture here. Here's our DSA of the foot, and then we'll take care of that in a second, and you'll see this. There you go.
Up on
Oh, yeah, exactly. It's all right. We have a little wire there, but look at that. Now look at that. Now everything is filling. Even the AT come back.
Yeah.
So now this is fantastic. So we definitely have done something really, really good for this young lady, and we'll take care of that proximal lesion offline. So listen, man, on behalf of myself, Raman, Dr. Ajit, and David, and as well as Harsh, thank you so much for allowing us to participate in this conference. Really, really appreciate it, George. Thank you.
Yeah, thank you guys. Great job.